Good morning, everybody. Thank you very much for joining us today. I see that we've got a few people here, so we'll get started. So welcome to session 3A, Methadone, Opioid Overdose, and Supervised Consumption Site Data. My name is Sarah Clark. I'm the Medify Knowledge Broker, and it is my absolute pleasure to be introducing Tali Cahill. Tali has several years of experience working with and for people who use drugs. She's currently a professional practice consultant at the Royal Ottawa Mental Health Centre and a community health nurse at the Sandy Hill Community Health Centre. She is also the Eastern Canada board member of the Harm Reduction Nurses Association, a national advocacy group. Tali's research interests include supervised consumption, injection drug use for associated endocarditis, and hospital-based harm reduction interventions. So as Tali is presenting, please feel free to put your comments into the chat as they arise, and we'll spend the last roughly 15 minutes or so of our hour together doing Q&A. If you need any technical assistance, there should be a purple help button, support button at the bottom left-hand corner of your screen. So please use that if you need to. And now I will turn it over to Tali.
Thanks so much, Sarah. Thanks for that introduction, and thanks for everyone who is joining me. I'm coming to you from Ottawa, the unceded traditional territory of the Algonquin Anishinaabe people. And thanks for joining me. So today I'm going to be talking about my master's thesis research, which is basically a secondary data analysis of methadone dosage and opioid overdose using administrative supervised consumption site data. So I have no external financial support, and I actually paid money to the University of Ottawa to do this research. And in terms of my relationships with financial sponsors, I have received an honorarium from Medify previously, and I am an employee of the Royal Ottawa Healthcare Group, as Sarah said, in the Sandy Hill Community Health Centre. This research did take place at the Sandy Hill Community Health Centre, and for much of the time that much of the study period as well as the research period, I was the clinical lead of the supervised consumption site and managed the associated clinic. So I do not think that I can really be objective about some of the things I'm presenting. It is a quantitative analysis, but I will be talking to you about Sandy Hill Community Health Centre and the services they provide. And obviously I feel really strongly about the quality of those services as I work there. And so just be aware of that possible conflict of interest as you're listening to me. I'd like to acknowledge my thesis committee, Craig Phillips, Michelle Lalonde, Jane McCall, and also Sean LeBlanc from the Drug User Advocacy League and the Sandy Hill Community Health Centre, which allowed me to use this data. So the background, and I'm not going to, because this is an audience that I think is fairly familiar with both opiate agonist therapy and supervised consumption sites, I won't go into what they are too much. Obviously, supervised consumption sites are places where people can use drugs in front of staff who are trained to respond to opioid overdose. So supervised consumption sites collect a fair amount of data, and that data is usually, for the most part, is required by Health Canada, who give us our Section 56 exemption to operate a supervised consumption site. There's also data, and it's a little bit of overlap with data that's required by our funder. And for the Sandy Hill Community Health Centre, our funder is the Ontario Ministry of Health. And so there's separate reporting, separate but similar reporting that is given to both Health Canada and the ministry on a monthly basis. That data is generally not released to external researchers or provided to the public. There's a little bit of data the Government of Canada releases, but it's fairly vague, and I don't think it's been updated since COVID. At Sandy Hill, we have often released some of that data monthly to people around us, and we put it on our website when we had time to do that. But otherwise, this data is not really easily accessible for researchers or for the public. And I'll talk a little bit about that later on in my presentation. There's also additional data that may be collected by the site. And I think I was there kind of at the beginning of when Sandy Hill started its supervised consumption site. I'm not exactly sure why we collected some of the data that we did. I think some of it was kind of traditionally like Insight collected the data or data that we thought would help in terms of assessing risk factors or identifying special populations. But there is a small amount of data that isn't required, but that we do collect. The data collection is also generally anonymous. And what I mean by that is that people are required to register to the site. They do not, in Ontario, have to show any kind of official identification or their health card or anything that says that they are who they say they are. They're just asked to give a name. They're often asked to give an emergency contact if they have one, but there's no kind of verifying their name with any kind of other database. I'll also say that at Sandy Hill, as I think with almost every, if not every supervised consumption site in Canada, if they're associated with another health setting, like a community health center, those charts are kept separate. So it's not like that your supervised consumption site visits are attached to a nominal chart in a health center. It's usually kept very, very separate on purpose. So this is a kind of a small picture, but basically until recently, maybe a couple of years ago at Sandy Hill, we collected all of our visit data on a paper. And this is what that paper form looked like back in 2019, which is when my study period was. And you can see, in some ways, I'm a little jealous of this piece of paper because it represents somewhat minimal documentation compared to what a lot of nurses have to document. So quite one of the great things about working at a supervised consumption site is that there's not a ton of documentation or extra documentation involved in a visit. But we asked for people's a code, which is kind of again, a code that either they could suggest the letters or we would suggest letters and numbers to come up with. And then a handle, they could use their real name or any kind of other name. So we had hot chocolate, we had hot stuff, lots of interesting handles there. Risk factors here included methadone or Suboxone. And I think there was a kind of a suggestion, at least at the beginning when we operated the site, of that people were also taking opioids at the same time as they were coming to inject opioids, and maybe that would increase or their risk of OD. I think that was the impetus behind adding this there, but I didn't design this form at the beginning, so I'm not 100% sure. Obviously, then drugs to be injected, the route, at that point we had drug checking, and then once the assumption, we would assess the client pre-consumption and obviously post-consumption and document whether or not they overdose. So this is our main form of documenting a visit. And we had tens of thousands of these papers that were very nicely entered by our staff so we could provide our monthly reports. So in sitting in this room and in looking at all of these papers, tons of papers piling up, I thought about how this information wasn't like, how could we use this information to improve the care of our clients? I will say that also at the same time, it was March of 2020, and I needed a thesis topic that I could reasonably do, and qualitative research was really difficult at that point. So I'm not a statistician by background, but I decided doing something quantitative would be just a little bit more feasible. And I just want to disclose that it wasn't necessarily my first idea for a master's thesis. So I said, we're collecting all this information. What does that say about the care we're providing? Are the clients of supervised consumption sites on opiate agonist therapy? What kind of OAT are they on? And the big question was, is there a relationship between the dosage of OAT and specifically methadone and the likelihood that they would experience an opioid overdose in the supervised consumption site the same day at the visit? So if I look at the form, we asked people, whether they were on methadone or Suboxone, and people volunteered their dosage at the same time. And I'm not sure whether at the beginning we asked their dosage, but after a while that became standard where the dosage would be documented for people. And again, this is self-report of their dosage, although the literature suggests that people really they know what kind of dosage of OAT that they're generally on. And all of that was entered, and that's the data that I used to analyze in this study. So I did a little literature review beforehand, and I don't know if any of you who prescribe OAT have looked at this literature, but it's really interesting if you look at the literature on OAT, because a lot of it is published before obviously fentanyl arrived in the drug supply, roughly 2016, 2015 here in Canada. And a lot of it is done in the US. And methadone, as you probably know, is provided a lot differently in the US than it is provided in Canada, in terms of there have to be specific methadone prescribers that's fairly controlled. Not anyone can prescribe methadone, and it is accessed at specific methadone clinics. It's not available at pharmacies, urban pharmacies where you have a choice of where to get it. And so it's access to methadone is much more controlled in the US, and a lot of our studies come from the US. So just be aware of that. The other thing about the research on OAT is that a lot of the terms that we talk about in terms of outcome measures aren't necessarily consistent from one study to the other, and they aren't really well defined. So something like retention and care could be defined by 3 months of staying on OAT, or it could be a year. And things like overdose could be self-report or not. Just the research itself was not as robust. It was robust in terms of showing good outcomes in general, but when you look into kind of the details, it was really hard to compare one study to the other. However, could basically say that 60 milligrams a day would be a minimum therapeutic dose of methadone. Most studies suggest that, especially in the age of fentanyl, that more methadone is probably better, and that makes a lot of sense when you think of how much opioids that people are injected and have been injecting since fentanyl arrived. But the prescription regulations were last published, at least the CPSO regulations, in 2011, obviously before fentanyl arrived and before our current drug poisoning crisis. And those regulations kind of died out, I think, in 2018, if someone can correct me. And the way we prescribe methadone is maybe quite different now. Although in 2019, I would suggest that a lot of people were still using those 2011 CPSO guidelines to prescribe methadone, especially physicians. So nurse practitioners were allowed to prescribe in 2018. They probably, I'm guessing, used a lot of the same the same CPSO regulations that that physicians use to prescribe methadone. And there wasn't actually a lot of NP prescribing of methadone back in 2018. And so we have new recommendations that were released by CAMH in 2021, but obviously they're released, those are suggestions, and it's a little bit different from having a regulatory body tell you what to do. The data on supervised consumption sites is interesting because almost all of it, well, like over 60% of it, comes from Insight in Vancouver, which makes a lot of sense because Insight needed to have that research in order to justify its existence. At the same time, the downtown east side Vancouver is its own specific place. Although there have been supervised consumption sites in Europe for many, many years, they tend to be, there wasn't a lot of research coming out of them, and they tend to be a little bit more grassroots in terms of not necessarily having relationships with like scientific researchers, or maybe they just weren't interested in providing that kind of research and they didn't have to, and that's fine. But we have a really limited amount of data about supervised consumption sites in terms of whether or not people are on OAT, and overdose rates are really hard to compare from site to site because the definitions are different. And I've spoken about this in previous webinars, but like I personally use a definition that I don't love, but it's the application of a medication, the administration of a medication in either oxygen or naloxone. I will say that there are a lot of overdoses that don't require administration of oxygen, and where you can kind of prompt people to breathe. It's very labor intensive, but it is a very legitimate overdose response. It's just hard to measure that because it's not documented that well. And it really depends on the staffing of a supervised consumption site, whether you can devote people to kind of reminding people to breathe every 5 seconds or so. The literature that does exist on opiate agonist therapy and supervised consumption sites, there's I think a study in France, there's a more recent study in Toronto, suggests that there's actually a lot of people who go to supervised consumption sites who are on OAT. And I'll talk about what I found in a minute. So the Sandy Hill Community Health Center is in an urban community health center. They have addiction medicine prescribing on site in a fee-for-service clinic. Usually fee-for-service is not part of CHCs, but they have a special kind of relationship with addiction medicine prescribers. So they do it on site within like 10-foot walk of our supervised consumption site. And it's methadone dispensing is available at many nearby pharmacies. There's one in the same block, there's one across one street, one across the other street. And I talk about this just to show that, to give you an idea that there is really a lot of access to both traditional addiction medicine and to methadone right in the same location or within a few hundred feet of the supervised consumption site. And that's not the case for all supervised consumption sites, for sure. Documentation, again, as I said, during the study time period, was all on paper. The substances used and OAT status was based on self-report. The opioid overdose that I measured was all observed by staff who are nurses and trained social service workers or social workers. At this point, the peers and people with lived experience did not work in the physical room, and you'll see a little bit why in the next slide. A limitation that I'm going to mention now and probably 3 more times by the end of this presentation is that the client codes were not verified at visits. They're paper forms, and there was not a really wonderful way to verify whether people were using consistent codes. Additionally, there are 4 supervised consumption sites in Ottawa, and all 4 used a different strategy to come up with a code. So people could, if you used all 4 different sites, you could have all 4 different codes, and that is obviously going to be very confusing for people. Another thing is that people who inject drugs, we know, are heavily, heavily stigmatized by the healthcare system, by all of society. And people may not have wanted to use similar codes throughout their stay or throughout their visits for very good reasons and to protect their privacy. And so they couldn't be tracked. Even though in their registration, they didn't have to put their own personal information, people were very, very understandably careful about this information and where it went. And so the codes weren't verified and people had really good reasons, whether by error or on purpose, to use different codes. So this study, and it's a major limitation of what we can infer from this study, is analyzed by visit rather than by unique client. So the population is the 12,999 visits in the 6-month period. It's not by unique client, and we could not follow people longitudinally with any degree of accuracy in this study. And that causes a lot of issues, but I still think the information is worth presenting. So here is roughly, 60% of the supervised consumption site at Sandy Hill. It's a 5-booth site. 4 booths are right here. There's one more booth on the left, and we're roughly sitting. The camera is roughly focused, sitting where the nurse or the harm reduction worker would sit. It's about a 10 by 20 space. It's very small. So I know that currently the people with lived experience aren't working in the site. They are doing intake and also post administration and stuff. So just so you're aware of how and why it's staffed that way. So my study, as I said, is a secondary data analysis of the data that I talked about. I did descriptive analysis of people's registration. So it's the one-time form that people filled out when they came in the site. I did descriptive analysis of what OAT people were on, what substances they use, and how often they overdose. And then I did some correlational analysis of the relationship between their methadone dosage and opioid overdose. And that's what I'm presenting to you now. So by the end of the study period, there are 273 people registered to use the site. Again, we can't really track visits by unique person, unfortunately, but just so you're aware, people visited more than once. So the study, the visits that we measured, or I measured, were 12,099 visits. Obviously, if you do the math, people visited more than once. And I will say, from just an observational perspective, that there were many people who would come once a week, and then we had people who were there 6 or 7 times a day. It's about 75% male, which really roughly tracks to a lot of services, harm reduction services, whether they be needle distribution, and just the population of people who inject drugs tends to be a little bit more male than female. Most of them were aged 25 to 44. Again, that is roughly consistent to the other information that we have about people who inject drugs in Canada. And they're mostly white, although the way that racial and ethnic data was collected wasn't wonderful in that people could only put one thing. And as a mixed person myself, like if you're only given one thing, sometimes you put the most obvious thing, or sometimes you don't fill out the form at all. And so that I'll speak a little bit about the problems with this data, but just from what we know and what information people gave us, they were mostly white. And then most reported a history of non-fatal overdose, which if you have read any of the literature, makes people, obviously they're at a higher risk of having a subsequent fatal overdose if they've had a non-fatal overdose in the past. And these are the substances that people used from May to September of 2019. Most of it was fentanyl. This, and I, just so you're aware, this is before kind of widespread safer supply prescribing in Ottawa. So that number has increased since then, but I think even current numbers show that it's a site that where fentanyl is heavily used. And I think our crystal meth numbers have come up a little bit, but so people were using more fentanyl than other substances for sure. And our overdose rate, which is the chance of someone having an overdose over at a visit, was 2.2%, which is actually higher than some of the rates reported by Insight and by some of the limited research we have out of Europe. Again, really hard to compare because that definition is not standard. And I would say we also have if you think about that picture I just showed you about how small the room is, it's one of the smaller supervised consumption sites for the number of booths, and we're kind of right on top of people for better or for worse. And so we really know when people are overdosing, and I think that we tend to document that a little bit more heavily, and a little just because we see people, we're measuring them all the time, we're 2 feet away from them. So anyway, that's my quite biased opinion of why our overdose rate is higher, but who knows? We're not sure. Obviously, the drug supply is not consistent from place to place. And yeah, so it's really not an important number other than comparing the overdose rate over the course of time at one site. But I'm just showing it to you so that you're aware. So 48.9% of visits, people reported being on OAT. Almost all of that was methadone. So at 45.3% of visits, people were on methadone. And that roughly tracks to the limited existing research we have about OAT and supervised consumption site clients. And I think this is a really important number because we have tended in the past to talk about harm reduction and treatment or recovery as two separate things. And what I would suggest to you is that there are a lot of people who are on treatment, getting treatment, interested in treatment, who are also using harm reduction services. It doesn't seem like a wild thing for me to say, but I think that just, the harm reduction, we treat people whether they're on treatment or not. We see people at various stages. It's people are still interested in getting care for substance use or using OAT in order to avoid withdrawal or reduce their cravings or make their mornings easier, even as they continue to inject drugs. And I will also say that almost all of our visits, 99% of them, were for injection drug use. So that's why I'm talking about injection drug use so much, even though some people do snort drugs in our site, but very few. So unsurprisingly, visits where people reported using opioids were more likely to result in opioid overdose. That is not shocking. However, there was no difference in the likelihood of opioid overdose for visits depending on whether a client was on OAT or not. And even if you kind of just studied the group of visits where people use opioids, still there was no difference. So there was no reduced chance of people having an opioid overdose if they reported their own OAT. And that is surprising because we know that OAT reduces people's risk of overdose on a kind of population-wide basis. And so I'm going to give you the reason for this in the next slide. So this is just a frequency chart of the methadone dose in milligrams. And you will see that 30 milligrams is by far the most common dose that people reported. And if you remember, either from your own personal prescribing experience or from my slide a few slides back, 60 milligrams is considered to be the minimum therapeutic dose. And again, if people are using fentanyl, it probably is higher. So the majority of people coming into this site, roughly the majority, there's a little, a lot of people are on only 30 and a lot of people are under 60. If you take a look at the methadone dose for substance use, the picture is even clearer. So on the left-hand side is the frequency chart of methadone dosage for people who reported using opioids at that visit. And again, a lot of it is under 60. The vast majority of the dosage they reported is under 60. For people not using opioids, and again, because there's various percentages involved, they didn't just limit to stimulants, it's just everything that's not opioids, they have a much greater chance of being on a higher dose of methadone. You'll also see that people's dosages are just in general not super high in terms of being like, not a lot of people over 150. And I think, and I would love people's opinion on this, but I think this partially reflects some of the CPSO prescribing guidelines about limiting methadone prescribing to a certain amount. I feel like it's 115, 110 if people didn't have an ECG on their chart. And so that could explain part of it. I think that we're now prescribing more and more methadone, but if you look at the fact that most people were using fentanyl on the site, they're still not getting a whole bunch of methadone. They're not reporting really high doses. There were very few that were over 150. So just to summarize that, there was no correlation between OAT and opioid overdose at all, and no correlation between methadone dosage and opioid overdose. 30 milligrams, most common dosage of methadone reported, and then higher doses of methadone reported by those using non-opioids. So what does that mean? So because we can't tie the visits to specific clients, unfortunately, two things may have happened. And what I would suggest from my anecdotal observations in the site is that both of these things happens. But a lot of clients report subtherapeutic doses of methadone, or those on a low dosage of methadone visit supervised consumption sites more often. And again, my study can't show this, but I don't think people would be surprised to hear that both of these things happened. And that what I saw and what a lot of people say is that people would start with their 30 milligrams and they would never actually get to the point where they could increase their dose. They would never get the 30 milligrams in enough days in succession. They would stop going to the pharmacy and they would just keep on restarting over and over again. One thing we do know is that that low dosage of methadone that people are reporting, it doesn't seem to protect clients from subsequent non-fatal opioid overdose. And that is not surprising that there wasn't any correlation, because we know that the minimum therapeutic dose is probably 60 and probably closer to 100, if not more than that. So the strengths of this study, it's a large data set, 12,099 visits. There is very limited missing data and very few outliers, like way less than 1%. Non-fatal opioid overdose is independently observed rather than self-report. And the criteria that I use, again, administration of naloxone or oxygen is very, very objective. This, to me, is a unique chance to examine supervised consumption site data, and that's probably the biggest strength. Again, it's not information that's made available to researchers, and the research that's been done on supervised consumption sites has only until recently involved actual people who use the sites or clinicians who work in the sites. It's a lot of the research was done by outside researchers who may not have understood the nuance about how the information was collected. Again, limits the significant limitation of not being able to tie visits to unique clients. It makes it really difficult to say what we can infer from the results of the study. It is a single site study and it is for a certain time period, roughly March to September 2019. And things have changed a lot since then. So the drug supply has changed. We now offer slow release oral morphine a lot more often. Safer supply is a big thing in Ottawa, especially. Also, since COVID, the guidelines about prescribing methadone have loosened for a lot of people. And so some of the things that we can talk about how methadone was prescribed in 2019 wouldn't apply for now. So my recommendations based on this information is, first, that when I was doing this study in 2020, I was very jealous about all of the COVID dashboards were coming out. So you could get data, almost certainly daily, accurate data about the number of cases of COVID in the world, how many people died, how many people were getting COVID every day in your city. supervised consumption sites collect a lot of very good data that is never goes anywhere. And so we don't have dashboards about opioid overdose. And although this would be great surveillance data and may help protect people in terms of being an early warning sign about what's happening on the ground of overdoses, we don't use it that way. And that data that's been collected for many, many years at every site, it goes somewhere, and I'm not sure that it's used for the purposes of improving care, keeping people safe. And then, so that leads me to question whether or not we should be collecting all of this data. So if we're going to collect it, I think we should use it. I think it's really important to get the perspective of people using our services. So people who inject drugs, in terms of what data they feel comfortable providing and how they want that data to be used. Because we know that these supervised consumption sites are very busy. Having to provide a lot of data before you come in means that you're waiting for the service. It can feel like you're being surveyed. You're not sure where this data is going. And there's a chilling effect that can happen when you are asking people for a lot of information before they use a health service. And we know that from the literature about other health services, especially in terms of HIV. Like, you ask people a lot of stuff and they tend to get suspicious. And we want to encourage people to use services, that the limited services they have, to keep them safe, and we don't want to discourage them. So I really got into the concept of data justice when I was doing this study, because I just wondered, where we need to use this information for good, or we need to think very critically about why we're collecting it. The other recommendations about methadone prescribing, I will disclose, I am not a nurse practitioner. I do not prescribe methadone, so I can make only limited suggestions about methadone prescribing. But what I would suggest is that we have, in the past, I think it's changing, we have tended to think about OAT as either as like a binary state, like you're on OAT or off OAT. And I think what my study kind of shows is, and what is really probably obvious to all the prescribers, is that that's not really a clear picture of whether treatment's going to work for people. So the dose is really important. So there's doses of OAT that can protect people, and there's doses that can't. And I know that methadone prescribing is really difficult just because there's such a high risk of iatrogenic overdose. At the same time, people who are constantly on this vicious circle of starting and stopping again, there's not a lot of benefit to that. And that's why I've been heartened by kind of recent recommendations, from the PHI group about adding slow release oral morphine on top of people's methadone in order to provide them a little bit more relief from withdrawal, a little bit more reason to stay on methadone. Because I will tell you, and I'm sure many of you have heard this, like, people are like, what's the point? Like, 30 milligrams isn't going to touch me if I'm doing half a gram of fentanyl in a day. 30 milligrams, it won't be for weeks, if not months, that I get to a dose that will actually help me feel better in the morning, help me reduce the amount of fentanyl I have to buy. And that brings me to kind of my last recommendation, is that quantitative research is really limited into what it can show you about how people are using drugs and how people are using OAT. Like, all I can present to you is really numbers, and people put a lot of faith into numbers, but it doesn't really tell a story to me about how people are using OAT, what the problems there might be. And I can only surmise that a lot of the limitations that we have had about methadone prescribing make it difficult for people to get to a therapeutic dose. But what we really need is qualitative research about how people are using OAT, and especially in terms of whether they're using it, like, are they using it to save money? Are people using it so they can wake up in the morning and not be dope sick and get on with their day? Like, people are not just using OAT in order to stop using drugs, and that is fine and great, and whatever keeps people alive and happy is wonderful for me. But it'd be great to get people to do research to tell those stories, because I think that this idea, again, the kind of binary state of harm reduction versus treatment is very obviously not the whole story here. And until we recognize that people have all sorts of different ways that they want to use drugs and OAT, that only by kind of hearing those stories can we really tailor the services to people who use drugs to help them stay on whatever treatment that they would like to be on. And my last slide is basically just kind of a reminder, and it's a concept that's very important to me, and I've already talked about it a little bit, but harm reduction programs are part of the spectrum of substance use care. So we see people, and I'm talking about we at this point, but in supervised consumption sites, we see people whether they're on OAT or whether they're not. And all of us will help people. If people talk about wanting to get on methadone, I can speak for Sandy Hill. I think I can speak for every supervised consumption site. We will do everything in our power to get people on whatever treatment they would like to be on, even if it's something that I don't even believe in. They want to get on abstinence-based treatment where they've had horses all day and there's no evidence behind it. If someone is really interested in that, I will help them do that. Because I think that's part of my job as a harm reduction nurse, and it's certainly a big part of why we do supervised consumption site work, is to help people meet their needs and stay safe. But we do see people when perhaps addiction medicine prescribers don't see them, and so we have a different perspective on the care that's provided and how it's provided than you might have in an exam room. And I've worked in both settings, and people tell a different story, maybe even in the same day, a different story about what their recovery goal is or isn't. And so I think just we need to be kind of aware of that. And we really need to get some of this data and some of the perspective of staff who work in harm reduction programs into well, we have to publish about it, we have to do research on it, but we also have to solicit their opinion. So we tend to kind of put a lot of faith into a biomedical model that harm reduction hasn't traditionally been a part of. I think that is changing. I'm really excited by some of the advisory groups that I'm working on that have people with lived experience. They have frontline harm reduction staff, they have physicians, they have nurse practitioners. I think that we need more than that, because we're really going to miss the picture or get a really late picture of people's substance use if we're just relying on large scale clinical trials, all of that stuff, because things like benzodope or xylazine wounds, that's stuff that people on the ground see first. And so we need to get that information up to the people who can make policy decisions and the people who are doing, research. We need to get that information to them sooner. And so we need to really work more collaboratively than we have been. And that is the end of what I have to say. And I'm hoping there are questions. Oh, now I can see the chat.
Thank you. Thank you very, very much for that, Tali. Amazing presentation. I have lots of questions in my head,
Okay.
and one has come up. Can you comment on whether people on higher doses of methadone had lower rates of overdoses, or if they were less likely to report that they were intending to use opioids?
So there's no real relationship between the dose of methadone and overdoses. And part of that is, we don't actually have a high rate of overdoses at our site, even though it's higher than some of the other sites. So it's really hard to kind of show a statistically significant correlation between those things. So I would not say that there is any relationship between dose of methadone and rate of overdose. There's nothing that I could see that was significant. So I will say just correlationally, people who reported higher doses of methadone were less likely to use opioids. And you can see that a little bit from that it's a Uman-Whitney frequency chart, if you want to use a technical term, but you can see that so people who were not intending to use opioids were more likely to report a higher dose of methadone. And I did not have a lot of information to separate that out by stimulants. I think there's something there. I think that there's been some conflicting evidence in the literature about people's use of OAT while they also use stimulants. And I think there's a story there to be told, especially about people's desire to get high and feel euphoria while they're still on OAT. Or perhaps that people are on high doses of methadone, they can be quite sedating and are using stimulants in order to kind of override some of that sedation and kind of get along with their day. My study couldn't speak to any of those things, but I do think that there's a story there that is just only beginning to be told about how people are using their different drugs. It's obviously, getting high is fine and people want to do that. There's obviously other things involved in terms of I've heard a lot of stories of people using stimulants in order to get off opioids, a lot of more and more reports of people using stimulants in order to counteract the effects of xylazine and benzodiazepines in their fentanyl. So they're way more sedated than they had intended to be, and the stimulants are kind of try to keep them awake. And I think that's only emerging, and we just need more data about that.
Yeah, I think that's really interesting. And I know you mentioned a few times, and I do see sort of the limitations that come from not tracking participants and having sort of longitudinal data. And I don't want to rub that in because I know that
It's okay. It's all
yeah.
good.
But I think there was so much in that data that's very sort of provocative. Like it sort of opens so many questions. There's so many questions that come from that as you say, there's a story to be told there, and so many beginnings in the data
Right.
that you have.
Yeah, I'm hoping that like my dream for this information is that people will think about, one, doing more OAT research that is about dosage and not just, again, that on OAT or off OAT thing, because that methadone especially, and you all know that who prescribe methadone, but you know, it's a very complicated drug to prescribe. Even if we get rid of we've gotten rid of some of the regulations around it, I mean, it's a drug that affects different people different ways. And it's, you know, been horrible stories of people overdosing on methadone, you know, and naloxone, you know, at the point of methadone consumption isn't going to help that because it's such a long half-life. And so it's complex. And I think that that's why we need to make sure that that research reflects that complexity and that nuance. And I think that's, you know, just overall, I think, you know, I'm a big believer actually in opioid agonist therapy. I think I believe in it more than a lot of other people. Like, I actually think that it really works for people. And that's from patient report to me of a lot of people who are like, I'm on my 80 milligrams of methadone, and then I do like 2 or 3 points of fentanyl a day. And that keeps me stable and safe. And I love that for people. I love that they found the way to use the tools that make their life work for them. And I think that I could have done the study and said, okay, OAT doesn't work. You know, like that's a conclusion that someone could have drawn from this information. That's not what I want to suggest. And that's not the story that I think is being told here. I do think that I know a lot of people who are on and off methadone constantly on and off. And it's like a roller coaster ride. And they are really trying to get some benefit from methadone, and it is not coming to them. And I think that that is important. It's not, and they're making an effort. And if you see that close to 50% of people on supervised consumption sites on OAT, like that is a real, it's obvious to me working in a supervised consumption site that people who inject drugs care deeply about their health, because otherwise they wouldn't be there. And we have waits, and we have people who are like wait 2 hours outside dope sick in order to be safe in the site. And so that's something, but they also, you know, they also want to figure out how to make OAT work for them. And it's not been working out, and they try over and over again. So I and this is again, not part of my study, but anecdotally, I think this is like people are on this cycle of being on and off. And I don't blame them entirely for feeling like it's just not worth it anymore.
Yeah. And I mean, I think it is like, again, we don't know how many participants this represents, but
right.
But like the most common methadone dosage was 30,
yeah,
which is known to be not a therapeutic dose.
Right.
Like that is a starting dose. That's where people
Right.
start. So, and you know, and that could be, you know, a bunch of people just starting on methadone, or it could be the same person who is either remaining on a non-therapeutic dose or cycling back.
Right.
And it's it's a really difficult.
And these are people who are at high risk of death. Like they're they are injecting fentanyl. They've had a history of non-fatal overdose. So it's the people who we want to see higher doses. Like no matter how the information is collected, I'd like to see people on higher doses, because I think that will protect them. Or we need to rethink like what we're doing. And I think that, you know, we do have some information from kind of the relaxing of the prescribing guidelines during COVID to show that it's actually safe to make methadone a little bit more accessible. I hope people are keeping on with those guidelines. And I think we just need to look also at just like how methadone is being prescribed, and whether or not our system incentivizes an amount of gatekeeping that isn't necessarily associated with safety. So again, because I don't prescribe methadone, I don't think I can criticize a ton how people prescribe it, but things that we know people will find very carceral, like urine drug screens, for example. Like, are we doing urine drug screens in an evidence-based way that actually provides good information for people, or are we doing it because just that's the way we've always done it? And so I think we need to really look critically, and I think that that's what a lot of people are doing now, again, without a regulatory body saying you can do this or you can't. I worry that especially outside of the urban centers, or outside of the people outside of the listening audience of Medify, that people are just kind of doing what they've always done, and that they may be under the impression that the patient is failing the treatment. And I would suggest that that's, in this case, not the whole story at all.
Yeah. Yeah, for sure. So we've got some
Sure,
in the chat here.
Now I can see the chat, so I can do some questions. Okay, so hold on. Solve this question. What do I think about making access to OAT prescription prescriber available in a supervised consumption site? Thinking about accessibility and barriers. Yeah, this is a question that I've asked a lot. And I have a friend who may or may not be listening who's like, I'm just going to prescribe everyone methadone who's coming in the supervised consumption site. Like, let's just give them. And, what if we could have a medical directive for methadone? Anyone can start methadone, and we can't. There's no, in Ontario, you can't have medical directives for controlled substances. We can't just be like, hey, anyone who comes in who's dope sick has 30 milligrams of methadone. Would that we could. I don't know how that would work. But having a prescriber available in the supervised consumption site. So here's the issue when people propose this, and they propose this with methadone, or propose it also with safer supply a lot, is that it's an anonymous service. So I don't have to show you my OHIP card. I don't have to show you any information. And that's really valuable for people. The evidence shows that when you require identification, it reduces people's willingness to use a site. And in Alberta, that's something that is proposed, and they've done a lot of studies, and people are not into that at all. So I think there's a little bit of a logistical issue when you have someone in a kind of anonymous site. I like to call it like it's like Las Vegas, like what happens in Vegas stays in Vegas. That's a little bit of how a supervised consumption site works. So I'm not sure how that would work if you have the prescriber just sitting there, and also things like how people use their drugs. Like, for sure, people will divert methadone. For sure, people are injecting their Cadian. Like, is the prescriber watching that? Are they changing their treatment plan based on that? I will say at Sandy Hill, and I alluded to this a little bit before, but like we have a clinic where people have nominal charts and they're getting primary care, other wraparound services, addiction medicine, and then we have the supervised consumption site. Although I might have worked in both settings, I like separate my brain. So I don't tell the prescribers things, and the prescribers are all very comfortable with that because they know that people need to have their safety, and that's part of the healthcare requirements of the site is that the site be a private space for that. So what I wonder is like when people have things that you might need to know as a prescriber, like, did someone get their dose today? Did someone not? And I know, hey, someone diverted this whole dose. Like, I'm not sure how that would work logistically. I think that, the prescribers our prescribers were there at the time of the study, Monday through Friday, like 9 a.m. to 2 p.m. We also would basically give anyone a taxi to any clinic that was open later. We would remind people about getting their methadone. Most of the nurses who work in the site have an addiction medicine nursing certificates, training. We're really familiar with OAT and how it works. We would walk people over there, accompany them. We would make it as accessible as we could, whether it's to the prescriber or to the pharmacy, to maintain consistency with dosage. There's maybe a way to make it even closer. I'm not sure if that's really the barrier. I'm not sure if that would improve people's uptake. And I just think they felt like it wasn't worth it. And again, I can't speak for people who use drugs at all, and I don't mean to, but I just wonder whether it would feel worth it to get that 30 milligrams and go back the next day, get their 30 milligrams, and the next day you're not going to feel it until it gets way up there.
Something that I wonder about, I find it difficult to think about the balance between, and you talked about this extensively, making sure that people, letting people know what their options are, helping people connect to the services that they identify as being valuable to them. And I wonder a little bit about how one balances doing that with not making people feel pressured or not making people feel like they are being judged
Right.
for not being interested.
It's a really hard balance to work to like a hard line to walk. And I think that at the same time, you can also say like you know, and I'm only going to speak for myself. Like I have been doing this work for a while and I've lost many, many people who are dear to me. Many, many people and colleagues and clients. And so what's also difficult is that I want people to stay alive and I want to do anything to keep them to help them stay alive. At the same time, I also don't want to stigmatize their substance use or things that are risks that maybe I wouldn't take, but things that people are doing. And so that is also a difficult thing. So it's hard to be, you don't want to be pushy about treatment, but you want to make sure it's really available. And if someone raises their hand and they want help, even if that help I feel like won't work or whatever, like if you want someone to have the help, at the same time you don't want to stigmatize their substance use at all, because then the service isn't welcoming, and then why would people go there? And so that is just a hard line in harm reduction, no matter how you do it. And I struggle with this on a regular basis. And I think we did a really good job at Sandy Hill just by making those services very available on site, that, outside of the room, the receptionist would be like, hey, did you still want to make that appointment? And that was a very light offer, like a light offer of OAT, or like, oh, hey, everyone, just so you know, the pharmacy down the street is closing now. Like, so you might want to get there if you need to. Like, so those are ways to make it kind of where you're just reminding people without kind of pushing them. Because I agree with you. Like, if you're like, go up to everyone and be like, don't you want to get your methadone? Don't you? No one's going to do that, because it's, when it comes right down to a supervised consumption site, it's very much like a bar. And if someone went into a bar and was like, let me talk about the Canada's high risk drinking guidelines, or like,
Yeah, I was
why
just
would you
thinking
go to
about
that
it. Like
bar?
every time I went to a bar to get a drink,
Yes.
and they say, have you heard about naltrexone? It's
Yes,
like,
no, no one would go in. And so that's it. I think that's difficult. And I think that's, I think that's why people need to kind of, respect the place that substance use has in people's lives, because that's the other thing, is I don't know what's going on with people. I don't know. And I'm fully aware of many people where substance use, like we're using opioids, they feel like that saved their lives, where people have pain that I know is not going to be treated in any other way. It's really hard for unhoused people to get access to decent pain relief. They're not getting, physiotherapy. Like, there's lots of reasons that people use drugs. So that's, I guess, part of the other thing about kind of pushing treatment is that, are we sure that treatment is going to actually meet people's needs in terms of like why they're using substances.
yeah. Christina has a really interesting comment here. I've also heard that this confidentiality umbrella adds to the stigma of injecting rather than showing acceptance. Not sure if you have any thoughts on that. I'm so happy when my clients use the site, as I know they're safer.
Yeah. I think, it's the stigma is so complicated. A lot of people, a lot of the clients of the site assume that we all shared all the same information, and I think that they would find that kind of artificial barrier between what happens in the clinic and the exam room and that happens in the site to be really weird, because they're like, oh, it's the same people. And as clinicians, though, we take the idea of privacy and confidentiality and personal health information really seriously, because that's our background. And I think this is a big problem when we're offering services to people whose, substance use is so heavily criminalized in our society that, it makes sense that people try to protect that information. And I know that increases stigma, the fact that we like hide certain things and all that, but like there really isn't, if we're going to continue with this experiment with prohibition many years after it's failed, and have this weird room where we've decriminalized drugs and everywhere else it's criminalized, then that, like, these are odd workarounds for a problem that has a much easier solution that people may not politically be ready for, but is becoming increasingly obvious to people. That's not a great answer, but like, I think a lot of the clients would tell the prescribers and tell us in the exam room that, oh yes, I do use the site, and people would document that as safety. And I think that's And I do think it shows that people are really caring about their health. I think it's important to document those harm reduction strategies. But I don't blame people for not wanting to be public about their injection drug use, because we don't treat people very well when they are open about it.
Yep. Any other questions or comments from anyone? We've got just a few minutes left. I have one question that perhaps you can't, it's not going to be a very well-formed question, but
Okay.
I'm thinking about, so the time frame that in which you collected data, which was March to September 2019.
Yeah.
And I think the thing that I'm thinking about is how much, what was going on with heroin at that time, and how much, like, people, and clearly people cannot be sure about what is in there. I don't know if you were at the Toronto Drug Checking Service talk yesterday, but
I wasn't, but
yeah,
yes,
that was a good talk, and it was.
I'm gonna see it. I'm gonna watch the video for sure.
And it was about like how, and this is, you know, more recent, but like how shockingly little of the drugs are what people expect them to be.
Right.
I wonder if you could talk about that maybe.
Well, so the time frame is, so a part, you know, and this is a good question, that like, so we have, and anyone who's familiar with Sandy Hill will be familiar, we had a mass spectrometer that worked sometimes and sometimes didn't work throughout this time period. And I do not know whether it worked or didn't work, like for much of this study, because I don't even know if we kept track of that, but sometimes people knew what was in it, sometimes it wasn't. When we could test it, there was very little heroin. And it was fentanyl. And I think most in 2019, I don't think I saw a real benzo opioid overdose in Ottawa until fall. The time period I chose is really just, you know, we started to document methadone dose in March. And so that's the beginning of the time period. And then my issue is that if I chunk the time into too small, like it would be really hard to get meaningful information, considering our overdose rate is so low. So I need to have enough overdoses so that number could create anything of statistical significance. And so what I did is I was like, okay, so, you know, Ottawa, everyone knows, really cold, like summer, things tend to be different in the summer. People come out and use services more in the summer than they do in the winter. I do know now that there's a lot more carfentanil in the supply during that summer of 2019. You know, so I'm not sure if people were necessarily aware of that towards later on. And that was another good question of like how people are using drugs, given the difference in the how people are using OAT, given the difference in the drug supply, is a whole other topic. And then I stopped it in September once because I had enough overdoses, and I felt like just weather-wise, I was getting a kind of a somewhat comparable picture, but also because at that point, starting later fall in 2019, that's when the safer supply prescribing started increasing in Ottawa. And that is a big confounder for this study. And I think that introduces a whole other component into how people use OAT or how they don't use OAT. Although I think that is a really important thing to talk about and to research, that would have messed up what I could determine. So I didn't want to include that. But that's and a lot, and in Ottawa, safer supply is often prescribed with methadone and is prescribed in an OAT clinic, a kind of more traditional clinic. So, you know, that's all it is to say that is like, there's so much complexity in how people use drugs and use OAT, and we just need to look at that further. That's my sum up thing.
Yeah. Well, we're just about out of time, so
Great.
I've just put the link to the session evaluation in the chat, and it's also in the description for the session on the agenda. Thank you to everyone for attending. Thank you, Tali, so much for that really interesting presentation. So now we're on a break now from 12 till 1. So go have your lunch. There's also a 40-minute, at 12:10 we'll be starting a 40-minute all-level yoga session. If anyone would like to get some stretching and movement into your day. and yeah, our afternoon sessions will be resuming at 1 o'clock. So yeah, thank you very much, everybody. Thank you, Tali.
Thanks.
And see you
Thanks,
soon.
Sarah.
Thank you.